welcome everyone. I'm Melody Mendez. I'm an anchor with NBC 10 Boston and NECN. It's a pleasure to be here. It's an honor to be here with many of you. I'll be your moderator, and I hope this goes as well as it can possibly go. Your names are testing my phonetic skills today. So with that, let me introduce each of you. So Ami Bhatt is at the end, Chief Innovation Officer at the American College of Cardiology. Tommaso Danesi. Tommaso, did I get it right?
Yeah, that's correct.
Okay, good. Director of the Endoscopic Valvular Program at Brigham and Women's Hospital. Jorge Plutsky. Jorge, that's the one I can say. I got that one down. Director of Preventative Cardiology at Brigham and Women's Hospital, correct?
Yes.
Okay, and then joining us remotely over there on the right is Joseph Wu, the chair of Stanford Medicine's Department of Cardiothoracic Surgery and Associate Director of the Stanford Cardiovascular Institute. So thank you all for being here. And before I get to the questions and answers to the meat and potatoes here, I want to acknowledge some really special people in our audience today. Mrs. Roberta Cohn, it's good to have you here, and her daughter and son-in-law, Mr. and Mrs. Leslie and Stephen Bernstein. Of course, we're here to celebrate your father, your husband, and it's an honor to be here and reading his work and what he did for the medical world is absolutely amazing. It's been an honor to actually get to know him just by reading his bios. Okay, so we're celebrating the 10th anniversary of the inaugural Dr. Lawrence H. and Roberta Cohn Forum in this studio. So Dr. Cohn was a pioneering heart surgeon, of course, particularly when it came to minimally invasive heart valve surgery. He saved countless lives through more than 11,000 heart surgeries, 11,000 operations. And among his many accomplishments is the fact that he was one of the first team to ever complete a heart transplant in New England in 1984. If we can, that seems like so long ago, yet what he did was so impactful that we're still living the ramifications of it. He unfortunately passed away in 2016, but Roberta, Leslie, Stephen, thank you so much for all being here. We really appreciate it.
Thank you.
Okay, so with that, let's get to the basics here. Heart disease is, of course, a global killer. It is often preventable, which makes this so frustrating for so many, right? This discussion today focuses on the future and solutions as we move forward. So let's start with a quick fire opening round if we can. I want each of you in 1 minute or less to tell us what innovation excites you when you think about addressing heart disease as we move forward. Jorge, go ahead and start us off.
Sure, it's a great question. The fact is that we've just beginning to leverage new technologies to ensure that patients get the therapies they need. And we've been stuck a little bit in old-fashioned approaches of hoping people will come in for visits and keep taking their medicines, but we know that's not good enough. And I think there are real opportunities for us to make sure that the therapies we already know work are actually getting used. It's very exciting, places like this where we pursue new opportunities, new drugs, new insights, and certainly there's been tremendous developments, but we can't escape the fact that we're not using the things we've already proven work and making sure that the public has access to them.
Okay. Tommaso?
Well, so what excites me the most is if you think about current medicine and the next future and the trajectory of the medicine, is the power that we gain from a preventive perspective and in treatment and AI and deep learning applied to the medical field along the broad variety of less invasive way and devices that are available and that we can apply to fix the heart disease. This is really exciting to me.
Tommaso, I'm glad you mentioned that because we are going to talk about preventative and also, of course, address AI because it's here and it's the future of pretty much every industry. Ami, what about you?
I'll be under a minute, but I've got to start with a story.
Okay.
That will explain why I'm telling my answer. I was a young adult congenital heart disease doctor, so lots of surgeries for patients that were unique, different hearts, different new types of valves. Great career. And I had a chance to give a big talk, and so people would sit around the table and kind of listen to you give your talk before you did it. And I was happy sitting in the room until one day Dr. Cohn walked in, sat at the end of the table to listen to me practice my presentation that day. I'm sweating now just thinking about having seen Larry walk in and sit there. But what he said to me after I gave my presentation and I ended with like future directions and he said, don't tell me what you think they want to hear, tell me what you really think. And so I will tell you, there are a lot of things we're going to talk about. Digital twins. This idea that for those kind of patients that I cared for, that I had the pleasure of caring for with Dr. Cohn, you don't know what you're going to get when you get in there. And you need really excellent people at the table, at the team to do these things. But the technology we have now, I can actually reproduce what you look like on the inside. I can see what that valve is going to look like inside you, and I can see the complications that may arise. I think there's going to be a point where it would be wrong to not test things in a digital twin and to test it first on a human someday. So that's what I'm really excited about.
That's fascinating. Joseph, how about you?
Well, those are all great answers. And what I heard at the end of all those is, what do you actually do about it? And I think just as Dr. Cohn made incredible innovations in minimally invasive heart surgery and mitral valve repair techniques and myocardial laser revascularization, among a variety of things that he pioneered, the surgeons and interventionalists of the current era are continuing to innovate, to develop new techniques, new devices, new ways of doing something to actually fix those valves, fix those vessels, fix the pumping function of the heart. So I think really the exciting thing for certainly those of us in the interventional space is all of the new technology that's being deployed and the new techniques. We're doing more and more operations now without having to actually stop the heart, where we let the heart keep beating and work on it. It would be the same thing as taking your car in for a repair, and while you're still leaving the engine running, the mechanic comes in and just fixes your engine. So that's what we're doing nowadays, and it's very exciting.
Joseph, the fact that you talked about that, I'm glad you mentioned it off the top, because that is closer to the end, but the notion of holding someone's beating heart while they are in surgery is absolutely mind-blowing, and we are going to talk more about that at length, so stay tuned for that. I do want to talk about diagnosis and screening, right? This is obviously where it begins, and I've come to understand that AI can be hugely helpful here. Jorge, can you start us off? What is the latest as it pertains to diagnosis and screening of cardiovascular disease?
Well, one relates to the fact of making sure that people know what their lipid numbers are. It's a position endorsed by a lot of our professional societies that everyone should know. Before the age of 21, everyone should know their lipid profile. Actually, there's no lipid police to enforce that, but you are better off knowing that because it helps define your risk. And I think beyond that, though, we've seen the ability to detect atherosclerosis, the disease that underlies ultimate coronary events, heart attacks, and strokes, that we can detect that before there's been a clinical event. And, how backwards were we when we were thinking, let's wait for someone to have an event, and then we'll be very aggressive about preventing it. The disease actually begins often in your 20s, and so the opportunity to understand risk, to calculate risk, and then even to see the presence of atherosclerosis early can help really fuel intervention earlier, and that can make all the difference.
And Ami, I want to hand things over to you briefly because you can talk to the AI, the promise of AI when it comes to early diagnosis and screening, as we just heard Jorge allude to.
Yeah, no, the data that's out there is significant right now, and it's probably more than the human brain can actually compute, right? And so that assist of compute power to say, I'm seeing all of these trends, and therefore this is really helpful. But specifically, we can use AI to say, off of this EKG, I'm pretty sure you have one of the following 3 diseases. By the way, one of them could be liver disease, which is terrifying. I don't want to know about my liver when I get my EKG. I wasn't asking for that, but we can diagnose things earlier. And why is it important? Because right now you need the expertise. You need the access to a cardiologist often. You need to be in a center. And so much of healthcare actually happens in rural areas, in areas that don't have the same access. And so if we can screen through data and find patients who may be at risk, who were originally going to present emergently, but now get to them sooner, that's the real magic of AI, is getting to people sooner. The challenge, and I'll just say it, is our healthcare system is overburdened. And so getting people in, right, we don't want to wait 60 days once we know we have a disease. So if we're going to use AI to diagnose earlier, we also need the right systems to get them to the right care at the right time once we do it. And that's the part that might be slowing down the use of AI in diagnosis and screening, which is we don't want to just diagnose and then leave you there nervous. And so we have to do both of those at once.
And a 60-day window, to be frank, in the healthcare system we're currently living in is actually a short wait comparatively, right? Joseph, I want you to speak to this for just a moment, the AI component here, because as I understand it, there's obviously a broad spectrum of what AI can do. Can you take us through that?
Well, we have the great fortune here at Stanford sitting in the middle of Silicon Valley, and AI is part of our daily vocabulary. And we in cardiac surgery have also picked this up. And for example, we're using AI to help us determine what operations to actually perform and to what extent we should do these operations. When we go in, we often have plan A, but there's also potentially plan B, plan C, plan D, so on. So AI has the ability to take all of the composite knowledge up to this point, including real-time imaging that we're getting from that particular patient, and then integrate all of that and help us decide, oh, we should add in this additional valve operation, or we should add in this additional bypass, etc. So we're using that for some decision making. The other really exciting thing that we're doing so that's already being done clinically. What's exciting on the research front is to use AI for the next step, that is autonomous interventions. So can a robotic system be programmed to actually perform parts or potentially all of operations completely independently? That's going on in our research laboratories, and it's very, very promising.
Okay, when you talk about that, I mean, my mind immediately goes to robotic surgery, right? How could it not? We still need human surgeons, thankfully. There's job security for a lot of folks in that. But robotic surgery is becoming more and more common. AI could obviously, as you just mentioned, play a role in that. So, Tommaso, do you see promise there?
I see more than a promise. So I see a word. I cannot agree more with Joseph about the role of AI and robotic in surgery. So we are targeting now something that is called precise medicine. So we are tailoring treatment around the specific patient. So we are using the deep learning, we are using our general knowledge, trying to tailor each treatment around a specific patient. So this is precision medicine. And the concept of precision medicine also applies to the minimal invasive approach to the patient. So it's an integrated part, and being less invasive means being more precise. One question is how the AI and the true robotic surgery because at this time, the robot is just an extension of the surgeon, is a pantograph. So when we think about a robot, it's something that is independently can perform something that I can perform, and maybe even better with more precision. So the open question is, what will be the role of the combination between robot and AI, and what will be my role and Joseph's role maybe in 15, 20 years since now?
That's an interesting question to pose. So, Joseph, do you want to take a shot at this one? I mean, what is the future? What does it look like for surgeons like yourself?
Well, I think, as Tommaso said, it's really right now an augmenting system. And so really the surgeons are controlling the robots. But we could see a transition over time, and it may happen faster than we think, where the reverse happens, where really the primary action is being done by some sort of computer program, computer intellect, and the human is there just to oversee. It's sort of like there's probably a lot of things in industry, a lot of analogies where there are a lot of things being built completely by robotic systems, and then you just have humans there in case a system gets jammed, etc. So I don't think we're quite close to that yet, but technology advances very quickly.
I do think it's important to note here that in all of my research about Dr. Cohn was how imperative he was when it comes to being minimally invasive. And when it comes to, looking at robotic surgery and moving forward, this is something that he was essentially pushing for before it even existed, right? That's why we're all here, which is fascinating. Let's talk about patient-centered care for a moment, because there must be challenges. You referred to this just a short while ago, right? Challenges of translating this new scientific technology, all of these new advances, to actually applying it, to actually allowing it to improve health at population scale. So I guess, Jorge, I'll start with you. Where do you see this going? What's the challenge there? Because as Ami illustrated earlier, there's a huge discrepancy, right? There's a huge jump that needs to be made.
Yeah, it's unfortunate. We see a lot of different barriers to care, why people are not getting optimal care. And on one end of that spectrum, even when a patient gets screened, identified as having a need for treatment like cholesterol lowering, and even when you initiate the medication to treat them, that at the end of 1 year, a very high and unfortunate percentage of patients are no longer on that drug. And there's lots of different reasons why they're not. We've never had the degree of disinformation people might get that is just not correct. There are hurdles around approvals and picking it up and different kinds of obstacles. And then you move from there to people who don't get screened as they should, physicians who may not be doing as good of a job as they could about teaching about why this treatment is necessary, including the fact that there are so many demands on them and new strategies to get them essentially out of the way. And then, of course, we have a huge issue with many segments of our population, either because of education or other reasons, not getting access to therapies and not necessarily having the agency to ask for that. I have patients who come into the lipid prevention clinic at the Brigham from often more affluent, educated backgrounds, demanding a lower LDL, and have referred themselves because their internist is not willing to treat them. And it's such a contrast to the patients who I'm trying to convince or see out there or getting admitted, as I'm doing currently on service at the Brigham, who have gone untreated despite our knowing that they had significant risk issues. So there's a spectrum of barriers. We really need novel strategies to overcome all of those barriers in order to really improve public health.
That disparity, I would imagine, is pretty stark. Ami, that perfectly leads into you because your job is how technology can improve patient access to care. So what do we need to do to move faster, to get people the care they need?
Yeah, I'll go in reverse order from complex to straightforward. I have a chip on my shoulder about oncology because you get the diagnosis cancer and everybody moves. They move heaven and earth, families move, people move. And you say heart disease and people don't move the same way. Partly because the way we've talked about it is very early with prevention strategies, and it's sometimes just hard when your daily life is busy to understand 20 years from now this could happen. Partly, I think, because when we talk about it, we also talk about, especially atherosclerosis or things like that, as a static, like you have a blockage. And the technologies that are coming now can tell you, hey, you have the beginnings of a blockage, and whereas this one looks stable, that one could be the one. Now, all of a sudden, you've captured somebody's attention. And I'm not saying that we need to attention get, but in a way, there's a lot of things vying for the average person's attention, and they need to understand risk. We also need to explain it better. So I think the science is going to enable us to drive those conversations better, thanks to AI. The second, less complicated thing is we're just better at reaching people now. I see my daughters on TikTok, only one, the 11-year-old is not on TikTok, but the older one, and we can really capture people's imaginations. And so we actually started a recent campaign for LDL screening. If you have not had a low-density lipoprotein checked in the past 2 years, we partnered with a large health system, actually multiple systems on the same EHR, where you get a message saying, hey, you haven't checked this person in 2 years, but the patient 2 weeks later also gets a message saying, hey, you should probably get this checked in a really nice way that's not a hard stop, but with information and graphics and things that make it look interesting that we didn't really used to do before in our paternalistic approach. So that's working. Just reaching out to people is actually working and communicating. And then I'll go to wearables for just a moment. There's this idea of consumerism. Everybody's got this. I'm wearing my thing. I'm not trying to do a sale for the thing on my wrist, so I'll put it down. But everybody's got something. Everybody's measuring something. And I think we as clinicians need to now say, it is not consumerism. It is patient agency. We have to be okay with that. More than that, we have to teach how to do that. And now if you're teaching relatively healthy people how to take care of themselves, the next step of getting the right LDL, then it all makes more sense. Right. And these kind of things are relatively increasingly accessible. I mean, in India, they're accessible to everybody. They do things at far lower cost. Yeah. So I think it's not consumerism, it's patient agency. It's probably the first step towards getting people to accept and understand tech.
Ami, you made the the comparison between the reaction to cancer and the reaction to heart disease. And I'm so glad you did, because in my notes, I have that as a layperson, as somebody who doesn't see the medical side of things or often understand the medical side of things, I know all of the cancer screenings I need to get. I know cancer has done a good PR job, if you will, right? We all know what we need to do to prevent ourselves from getting cancer if possible. When it comes to heart disease, in a way, what you were alluding to is that, yes, there hasn't been this PR campaign, right? There hasn't been something to scare people, sadly, in as much as cancer has. You talked about getting your lipid numbers, your lipid profile in your first comments. I've never heard that term in my life. And at 40 something years old, I would like to think that I know all of the things I should be getting screened for. So on that note, Joseph, I want you to talk for a moment, if you can, about patient urgency here and what Ami so eloquently put as patient agency. This idea that maybe a lot of folks just don't know, and not through willing ignorance, just because they don't know, the word hasn't been out there.
That's such a key point. This happens to me every single week in the clinic when I'm seeing patients. I try to remind them that cardiovascular disease kills more Americans every year than every single cancer combined. And that if they ever heard they had a cancer inside, regardless of how slow growing a cancer it would be, they'd want it out or treated right away. Yet there are people who have cardiovascular disease who say, well, I'll wait till next year, or I want to wait till this graduation or this vacation, etc. Very few people would say, well, I'll wait till next year's summer vacation until I get my cancer taken out. So it's really interesting that there's this wide disparity between how people approach cancer and cardiovascular disease. I think some of it is that cardiovascular disease is so prevalent and somewhat indolent that it just becomes almost like a baseline acceptance. Everyone knows someone who's had bypass surgery or something like that. But it's our job as physicians to increase awareness that waiting only causes more damage to the heart, and that we need to enhance this sense of urgency for the treatment of cardiovascular disease from the very beginning, from the screening all the way through the intense interventions. So I think that's a critical topic you've touched upon, and I couldn't agree more with what Ami said about this sort of strange difference between the approach to cancer and approach to cardiovascular disease.
I'll chime in with an anecdote around that that's always striking me. It's happened, several times in clinic, in a lipid clinic, where I'm seeing a patient who's been very hard to treat in terms of lowering their bad cholesterol, their LDL, or who sometimes get referred to me, as one patient put it recently when I said, do you know why you're here to see me? And they said, well, you're the guy who's going to try and talk me into taking a statin. And as you go through that, it's not uncommon after this, detailed conversation of the rationale, the basis, and actually I think we do a good job at that, but it's just inefficient. It's not uncommon to have the resident or fellow working with me say, even within their own HIPAA compliant disclosures of information, say, I take a statin. And when you look at them, I often say, what are you, 15 years old? And they go, no, I'm 25, I'm 28. And I say, why are you taking a statin? They said, well, my LDL is 120, 130. And although that's not very high, it's not optimal. And that contrast, to me, frames a lot of the challenges for us, because what does that resident doctor at the Brigham or that cardiology fellow at the Brigham know that patient we just talked about doesn't know? And bridging that gap is really at the core of effectively communicating what the issue is and why you want to do it. And certainly those doctors aren't initiating a statin early because they think it's harmful. They're initiating it early because they think there'll be benefits, far down the road. Actually connects to the public health strategy of, making some agents over the counter to increase access. But the teaching part is also important. I think bridging, what that professional knows versus what the public knows, is an important step, trying to find that bridge.
Absolutely. We want everyone to have access to the knowledge that these residents and that you all have. I need to talk about something that has no PR problem whatsoever, and that's the semaglutides that are out there, right? I don't think anyone in this room hasn't heard of a semaglutide at this point. You've seen the commercials for Ozempic and Wegovy and all of those things. this new generation of drugs, initially made to treat diabetes, right? They are now widely being used to address weight issues and still diabetes as well. Is it showing promising growth for, or movement, I should say, for heart health? How do you see that going? Is that playing a role in what you all are doing on a daily basis, Jorge?
Yeah, so full disclosure, I was involved with some of the clinical trials that showed benefit in
Right.
terms of the cardiovascular system. I think that cardiologists have long known when they would peek out into their waiting rooms and said, well, who's out there waiting to see me because they've had a heart attack or they've had a stent or they've had a stroke, that people realized that often the dominant feature was that patients were overweight and obese, and certainly an epidemic in America and Western society. We have evidence for the first time with those agents that even without a patient having diabetes, patients who are obese and overweight and had a high risk for cardiovascular disease, and even though their other parameters were very well controlled, their cholesterol, their blood pressure, that the use of a GLP-1 receptor agonist, in this case semaglutide, significantly reduced the risk of a future event and improved a variety of different risk factors. But the fact that you could do that on top of the current standard of care was really a breakthrough. And it really, for the first time, established that obesity is a disease, is a real issue, and there's an opportunity to improve outcomes, through the use of these agents. And of course, we just see that exploding.
Did you want to add
Yeah, 20 seconds for a story. We had a conversation last week. It's a bunch of cardiologists. And somebody said, so many of our friends are taking it now, and they're just really taking it because they want to lose those few last pounds or they want to do this. However it is, they got on the drug, a doctor prescribed it, so it's their business, we don't know their health. But the conversation that then involved was somebody else said, but look, even if they're doing it for vanity or for whatever else it might be, if it's improving their cardiovascular health, why are we telling people they have to understand the depths of the interaction of GLP-1, et cetera, and what the trial was? Our population is getting healthier. I just thought it was a really interesting conversation that we're starting to have about, what does it mean to get healthy and what are the right drivers? And so I think that conversation is also going to happen, especially now with this new data, that you don't have to be a full-fledged diabetic with heart failure risk to benefit from GLP-1 alone.
And is there room for judgment when it comes to how anyone chooses to deal with their health, right? So that's so important, and I'm glad you added that in. We've been talking about diagnosis and medication, preventative medicine, but I want to get to high-tech interventions like surgery, right? Minimally invasive surgery. This is what Dr. Cohn pioneered. This is why we're here today. Tommaso, you helped advance heart surgery so that it's less invasive. How did you do that? And why does it matter so much now?
So if you think about progress in medicine and in surgery, you can see two figures. You can see pioneers, and then you can see the workers. So Dr. Larry Cohn was a pioneer. So he was a person that was brave enough to break through the standard way to perform something that at that time they knew that was working and was working nicely, was fixing the heart. But he wants to pitch up and put a leverage on it, trying to provide the same quality at the same safety, but in a different way. So in 1996, he led a team that performed the very first minimally invasive aortic valve replacement. So it means that an aortic valve was replaced through a 3 inches incision instead of having the chest bone crack all the way down. And then you have people like Tommaso. So people that has built on Dr. Cohn's work, trying to integrate the latest technologies and devices in their practice, trying to sharpen the trajectory of being less invasive and committing their career and their work to the invasiveness treatment that they're offering to their patients. So, and my point is the endoscopic cardiac surgery, basically through micro incision of less than 2 centimeters. So I'm a from the other side of the ocean, so I go by centimeters.
We'll forgive you for that.
And so you can basically deliver the same quality at the same safety, so you can do the same operation. So basically, we are pushing the boundaries. We kept Dr. Larry Cohn's job as, you know, a wide and firm fundament, and we are pushing forward.
Joseph, I want to loop you in here from Stanford, from the school where Dr. Cohn got his medical degree, I believe. You can speak to minimally invasive surgeries and certainly what Dr. Cohn did for the industry. Can you speak a little bit to that for me?
Yes, of course. Thank you. Well, Dr. Cohn got his medical degree here. He met Roberta when they were much younger here on the West Coast, and they were classmates from a long, long time ago. Larry got his medical degree here, and he did his training under Dr. Norman Shumway, a world-famous pioneer in transplantation. And Larry was a bit of a character, and certainly considered one of the greatest graduates of the Shumway era and the Shumway program. And when Larry went off to the Brigham, one of the great stories that he told was that they were doing it a certain way at the Brigham, and he was basically asked, well, how do you want to do it? And he said, well, I don't think I want to do things the way that they're doing it at the Brigham. I'd like to do it the Stanford way. And that's what he was charged with. And he brought in a whole new different way of doing heart surgery. And he had outstanding results. And that went on for decades with his own pioneering innovations. But really, I think he grew up in an area where challenging dogma was very much encouraged. It was almost the religion here. It still is, in a way, and I think the world sees it in the manifestation of the high-tech companies in Silicon Valley, but medical innovation was sort of doing that even decades before. And I think Larry really benefited from that environment, and then he took it to a whole nother level with many more new inventions that he came up with.
It's fascinating to think of the courage that must have taken, right? Joe, I want to keep you on this for just a moment, because at the beginning you talked about holding a still beating heart. I believe it was you that mentioned that. The ability to do that, the ability to not stop the heart of a patient while you are doing surgery sounds absolutely extraordinary to begin with, and one with which you are very familiar. So can you talk to us about a patient undergoing this kind of transplantation and how that actually works? Can you tell us more?
Yeah. So this is kind of like a ladder where there are different rungs that you're working towards. And many years ago, people started doing bypass surgery. That is putting new vessels onto the heart while the heart was still beating, and that's pretty well developed now. And you're working on the outside of the heart, and it's mostly just stabilizing the heart and controlling some of the bleeding on the surface of the heart. But then as those techniques became more and more advanced, we started going inside of the heart and starting to work on the inside of the heart while it's still beating. And then most recently, a very interesting technology has been developed where normally in transplantation, you take the donor heart, you put it on ice, you bring it back, and then you sew it in while it's still. This new technology allows you to take the donor heart and put it on a machine that sends blood into the heart and keeps it nourished, and the heart beats. So while you're traveling in an airplane with that donor heart back to the recipient hospital, the heart is beating in this machine. And the standard way of implanting that heart was still to stop it and sew it in while it was still. And we sort of asked the question, well, why not just sew it in while it's still beating? We figured out a way to continue delivering blood into the vessels of the heart while we were able to bring it up to the field and then sew it in. That's really what was so exciting. You're literally holding a heart that's still beating. It's out of the patient, it's beating, and we're starting to sew it into the recipient. And what's most exciting about it is because it's already beating, as soon as you finish sewing it in, it's ready to take over the work of the pumping of the blood for the patient. And so they jump right off of the heart-lung machine and support, and they go right to the ICU. So that's a new innovation that we developed here a couple of years ago. And what's really exciting is that it's now spread throughout the country, and there are at least 15 different heart transplant centers in the nation that are now using it. So we think that this is a new way of doing heart transplantation, and we hope it expands the ability to bring hearts from further distances, hearts that are maybe not typically thought of as adequate donors. So maybe this will expand the number of hearts available, and therefore more patients will be able to get heart transplants.
Imagine what that means for so many organ recipients and folks on that waiting list. As we know, there are thousands. I did read in one of Dr. Cohn's bios, and I thought it was really beautiful. He called it a privilege to hold a patient's heart in your hand. And I just thought that was such a beautiful way of looking at a moment that's so important. Look, being in Boston, I'd be remiss if I did not mention CRISPR genome editing, right, in heart disease treatment. So, Ami, can you give us kind of a quick recap, a summary? What does CRISPR do? And how can it be applied to cardiovascular care as we move forward?
Yeah, this is going to seem like a familiar story to you guys, starting with cancer. So actually, this is hematology. This was kind of my first love. Sickle cell disease, something that many people have heard or familiar with. And there are times where people with hematologic diseases need stem cell transplants. And when you can edit a gene to take out the thing that gives you the illness, that CRISPR technology can be used for a variety of reasons, but here at Boston Medical Center, actually just several weeks ago, they did the first stem cell transplant with a CRISPR edited gene, right, for somebody. And just the whole team, the feeling that they had to know that they were going to make a difference for the rest of someone's life. I mean, hopefully everybody is still doing well, but I think that's so important. So what's next is we have cardiovascular genes that we know are making us more likely to have disease. And this is kind of what Jorge does for a living. One of them, for example, I'll just mention is lipoprotein little a. If you haven't heard of LDL, you have not heard of LP little a, something that we're working on. But in the South Asian population, we take up 25% of the world's population, 60% of the cardiovascular disease burden. There are certain things that make you more likely. So what if, instead of having to take a pill every day, in addition to what you're doing, et cetera, you could change some of that genetic risk in certain populations, right? Now, this is Aldous Huxley, Brave New World. We have to be careful as we go about it, but it's possible. I'm going to take that and take 1 second, however, to talk about something a little different. My 17-year-old, the TikToker, she is in AP Environmental Science, and the little one's in Model UN doing climate change. And both of them, when I told them my excitement about CRISPR one day when I came home, they were like, do you know what the climate is doing to respiratory and cardiovascular disease? Both of them came at me. And it's unusual that with a 6-year difference, they come at you with the same thing. And so I just want to mention that I think as we think of all these great new technologies, population health matters, access to basic needs matter, not even basic health care, and that I think climate really matters for this next generation. And so I just didn't want to not mention it today with them in mind.
Absolutely. And actually one of the audience questions, we're about to get to the audience questions right now. So one of them, I'll start with this one, Ami, if you don't mind, I'll direct it to you. So these were pre-submitted by our audience today, but here's one of the questions. And it says, how does a clinician account for differences in ethnic groups in light of the fact that most studies and guidelines are done or based on Europeans and men? For example, how do we use the ACC risk estimator in a South Asian individual?
Yeah, so perfect question. We had a webinar on this yesterday. The answer is use it with a grain of salt and then use your own judgment based on what you know and what you're learning in the literature, because we're not there yet. There are numerous studies. One is the Our Health study that we're running, where people who may not have been included in the original populations can join registries such that we can study those populations. So there's a lot of registry work, and some of that is even direct to patient now with technology, where it's not that your doctor has to remember that there may be a registry for you and your ethnicity and your disease, but some of the advertising we're doing now is direct to patients saying, hey, do you want to give us access to the back end of your chart? because we can actually take your, whatever your EHR is, go in through the patient portal, take that data and start registries. And so there's patient-initiated digital registries. So we're hoping to get patients themselves to be advocates and give their data and ask for more. At the same time, we're also training people. Tomorrow I go down to DC for the Clinical Trials Research Program, and that's to get more women and people who serve in underserved areas and look like the communities they serve to actually be trained to be a Duke or Stanford or Harvard, right, clinical trialist. Because not everybody is at those 3 institutions, but clinical trials need cardiologists who look like the people they serve, and they need to be in these communities in a trusted community, but somebody needs to train those people. And so that's based on philanthropic dollars to really make sure that we get doctors trained in the areas where these people live, who are trusted to do the necessary research, and that we go straight to patients when we can and say, would you like to contribute, because we want to include you.
Does anyone else want to weigh in on that? Should we get to the next question? All right, okay, next question, here we go. What are ways high-risk populations in particular can reduce their risk? As public health practitioners, what are some reputable sources of information we can share with lay communities we work with?
Well, certainly, we often refer patients to resources like the American Heart Association, the American College of Cardiology. Educational institutions and universities are often, reliable sources of information. And people have to be careful about getting information from other places where it's just not going to be accurate and, potentially quite harmful to be pointed in the wrong direction in terms of knowing, getting that information you need, and then applying it, empowering people to ask for the care and ask questions about, well, how come I'm not getting treated, or what about this opportunity? So there's, unparalleled ways in which people get information they never could before. And hopefully, with good, reliable resources, we can have more people taking advantage of that, advocating for themselves and their treatment.
Tommaso, do you think, are there any resources that you would advise younger people coming up in the public health industry to look to, since we know that you're on the other side, you're in the metric system zone? What have you got?
So basically, we are at the end of the process.
Yeah.
So basically, we try to use those data to try to forecast the result, and that's important to provide our patient what's going to happen, what can be the results. So basically, the way we can advise the population, it's a way more limited compared to Organ 1 or to MS1, because unfortunately we come on the field too late.
Yeah. So let me ask you this then, because a few of the questions actually had to do with results. Let's start with the sustainable results by using medication. So this is a specific question that says, is it possible to achieve sustainable results by using medication to bring down blood pressure? Or is medication just a temporary fix? What are the underlying causes of elevated blood pressure? What do you think?
Well, we absolutely know that medications work, and no surprise that in order for them to work, you have to take them. And in the vast majority of cases, you have to keep taking them. One of the strategies we've used at the Brigham that's an innovative one is to find people who are getting undertreated, and using an algorithm to have someone who's not a physician, not a nurse, but someone who's trained to implement treatment, not just to say, oh, you should go to ask your doctor, but actually to initiate care. It's quite shocking the extent of undertreatment we find, even in an excellent system like ours, where we think our doctors are terrific, that undertreatment happens. And sometimes when those navigators reach out to patients and say, you had bypass surgery or you had a stent placed, your LDL used to be great and now it's quite high, the answer is often simple ones like, yeah, I tried to get it renewed and I never heard back, or I moved and then I just fell off the radar. We can immediately go to saying, okay, well, that prescription's now waiting for you, and here's the basis for why you want to do that, and let's get you back treated. It's a simple answer that it helps to get the doctor out of the way, who's very busy and should be doing other things than trying to renew a prescription. The system, doesn't allow for that kind of checking in. Very old-fashioned notion of you initiate a treatment, you send the patient out, and you hope when you see them again in 6 months or a year that they've done it. Well, there are other ways to do that. And this strategy has been extremely effective in terms of getting people onto the right treatment, just based on addressing the simple barriers of why people aren't getting treated. And it's also is a very democratic way of doing it because it doesn't rely on education, affluence, and other things. It's simply saying this person's not had an event, but their LDL is very high. They should be on treatment. We can get that initiated in a fairly simple and effective way.
Tommy, did you want to add to that?
I used his program. I was practicing adult congenital heart disease, but I had a lot of patients who would give me their family members as well, who had basic hypertension, slightly elevated hypercholesterolemia. You have to put your ego down. I wasn't necessarily taking as good care of them because I was so busy in the OR with the next patient with a thing. And you have to say, you know what, I think you're actually going to get better care. I think the results we're going to see, I think they're going to be able to keep you on the med. It was the greatest program I ever enrolled my patients in. To this day, I say it. It was really good for them. At first, I was worried they were going to get advice from someone who wasn't me. Like, do I want that for my patients? But it actually turned out, I looked at my numbers, I looked at their numbers. Their percentages of follow-up were better with staying on the meds. We did it, and it really does work. By the way, it doesn't just work for the thing you did. When you engage your patients, if they were in for blood pressure, their cholesterol was getting better. They were in for cholesterol, their prediabetes never became diabetes, it got better. And so you actually saw these adjacent effects just by being in a program like that.
Joe, I want you to speak to COVID for just a moment, because as research shows, COVID-19 can have lasting impacts on the heart, unfortunately. What research, if any, is being done to monitor those impacts and to help prevent them?
Wow, I think what we're seeing from a COVID point of view is really much more on the acute level, the sort of catastrophic COVID and how to rescue that. I'd really have to defer to Jorge or Ami, for example, to maybe comment on some of the more chronic COVID-related cardiovascular issues.
Yeah, what have you seen?
Well, there are patients who suffer from symptoms that are associated with long COVID, and understanding that is a major impetus. The Brigham is part of a network trying to understand that. Still early days. As Joseph said, we're seeing a lot of patients come in acutely, but now we do have a significant percentage of patients who feel like they're still suffering shortness of breath and other issues, and trying to come up with strategies of how to treat that is still very much an open-ended question. Of course, good public health practices are still relevant and in place, and avoiding the COVID in the first place, matters. And so that's, just as important, even while we chase around and understand long COVID. It's better to not have the problem in the first place. That actually applies to heart disease and diabetes too.
Ami?
Wearables have been somewhat helpful in the kind of long COVID, if you will, population, in terms of just starting to get a better sense of, on the days I feel well, what do my numbers look like? On the days I don't feel well, what are the things that I'm doing? I'm not saying the wearable is diagnosing or treating. I'm saying it's a way to start keeping the old school log of what feels good and what doesn't. And people like Jorge need that information in addition to the medical information for their registries for us to be able to make meaningful changes. So again, it goes back to patient agency is helpful. It's a really tough thing to have COVID and feel like you've never gotten better. But some agency really helps with that, and it helps us as researchers.
Okay, the next question, any of you can take this, whoever feels most apt. What is the success rate and recovery process for mitral valve repair? Tommaso.
Well, so in experience center, if you refer to the most common type of mitral regurgitation, that is called primary or organic mitral valve disease, that means that the valve is too big for the hole. Basically, the successful rate of having a good repair is above 95%. So it's really high. Experience center can make you getting home with your own valve repair and with a very durable repair over the years, 30 years follow-up. Well, in terms of the recovery process, it depends on the way the surgery was performed. So usually if you undergo standard surgery for your mitral valve repair, it will take roughly 2-3 months to be 100% to your normal baseline and to your routine activities. With an endoscopic or minimally invasive approach, a patient should expect to be home within 4 days and being almost at his baseline in 2-3 weeks. That makes a huge difference, from psychological acceptance of the operation, and also the way all the surrounding people, the people that are surrounding the patient, can support the recovery process.
That's so important that you mentioned that, because I would imagine hearing a loved one needs heart surgery, you immediately go, oh my gosh, this is going to be a 6-month process. I'm going to have to be with them, take time off of work. But to hear back to baseline in 2 to 3 weeks, that must be a huge relief for families and loved ones who are going into this with the patient as well. Okay, next question. Prevention and treatment are crucial to risk management. So I'd like to know how we may account for the disparities in populations long facing higher rates of morbidity and mortality due to CVD, particularly African Americans. How do we incorporate this understanding into our prevention efforts?
So I'm happy to go first. I think also specifically when we talk about African Americans in America, we have to think about trust in the healthcare system and how we do that. There was a great study that many people may know. They refer to it loosely as a barbershop study. And this was where we had pharmacists in the barbershops, which was a place that people frequent and trust, and then see others helping get their blood pressure treated there. And the results were lovely. One example. Second, peripheral arterial disease. So if you have blockages in your arteries, those are just heart arteries. You can have the same in your brain. You can have them in your legs. Peripheral arterial disease leads to more amputations in African Americans than it does in non-African Americans. Why? Why should that be? Partly awareness. And so there are communities actually have vans that go into the areas where people live with trusted individuals, and then are screening people's legs to say, hey, you're at risk, you may need care. And so we have to go into the community. I think the key from my perspective, and I'll hand it over, is you can't go to a community and say, we're going to take care of your health. Like, that doesn't work. So it's going to the communities and saying, how can we improve health here? What are the key issues you're seeing? And really, that relationship is incredibly important, and I think it's our responsibility as a medical community to take that approach rather than the maternalistic or paternalistic, I will fix this for you. I can't fix this for you. We need to do this together.
Does anybody else want to add anything? Is there anything I haven't asked about or that has come up throughout this conversation that you wanted to touch back on?
Well, I would say that as much as the innovation is really exciting, we talked about new therapies and major progress with drugs that cause weight loss and lowering cholesterol, controlling blood pressure, intervening on mitral valves, and doing coronary bypasses. Lifestyle still matters. It does matter how we eat and how active we are, and that can be an important component of not getting to the point where now we're trying to overcome other issues. And recognizing that we need to do a better job of explaining that and providing information about it, having people understand it, and not in a way where they're just beating themselves up of like, I know I can do better, right, but sort of making the small steps in terms of improving their overall health for themselves, for their kids is often a good motivator, and those still really matters. I like to tell patients I can't put all those benefits into a pill. Even though I do have pills and medicines now that might cause weight loss and other therapies, we just can't underestimate how important that is, and even recognizing the ways in which certain segments of our population don't have access to things like better food, and we talk about deserts in terms of nutrition, and even patients who will tell me, well, I understand you want me to go for a walk. There's no sidewalks in my neighborhood, and it's quite dangerous for me to go for a walk in my neighborhood. And so it does have a public health element to it, but it's something not to be forgotten along the way.
Absolutely. I think, Ami, that goes back to what you mentioned too about the wearable. Just getting information and patient agency there is so important. So before we go in closing, I want each of you to answer this very briefly. What are the most important ways to keep your heart healthy and to advocate for yourself if you do have heart disease? For folks watching, what would you each say? Joe, do you want to start us off?
Sure. I think the most important thing is to avoid heart surgeons. I think you want to eat well, sleep well, live a healthy lifestyle.
Make it sound so simple there. Ami, how about you?
I don't think we can overestimate the effect of stress on our heart. I don't think we can underestimate how we just don't give mental health the attention it needs in its contribution to cardiovascular disease. So I would say, as a mini start, take time for yourself, slow down a little bit, put the phone down when you're talking to your friend or your family, find ways to connect. If you can walk safely, walk instead of grabbing a glass of wine with someone, right? Just those little things. It can be 90 seconds at a time of deep breathing. But I think we all need to move towards just a generally less stressful life. And then, of course, if we or our loved ones have mental health problems, recognizing the stigma is still there, even though it's less, get people the help that they need, whether it's, online or in person, but find that. But I think stress is just, we don't talk or think about it enough, and we need to.
I think that Jorge, you nail it. So lifestyle, so try to stay healthy, since there are some variables that we cannot work on. So we cannot work on our gene, we cannot work on our cells. There's a lot of work to do on from the behavioral standpoint. And what I do recommend to almost every patient, so start taking care of your heart before hearing from him. Because, you start taking care of your heart when you have some sign of a disease. But, I think that the process can start 20 years earlier and bump the raise of any cardiovascular disease that might be preventable.
It's an important message. You can only control what you can control, right? And often it is that simple. Jorge?
Well, we've all arrived at the same sort of recommendation. I think one of the ways to get at that same information is that you should know your numbers. And so if you know your LDL, you know your blood pressure, you know your weight, you know your glucose levels, then you have to then understand, well, what do those numbers mean? It means you've gone to a reliable source to understand what that might mean in terms of your risk. And then that empowers people to then go and make sure they're getting treated appropriately. And importantly, I think not being scared of the treatment. I sometimes cast this for patients who, if it was 1940 and you showed up with a terrible pneumonia at the Peter Bent Brigham Hospital, that was a major threat to your mortality. When antibiotics came along, that went away. And then cardiovascular disease became the biggest threat. So you could show up in 2025 to our emergency room with a horrible pneumonia, and I could come in and say, okay, I've got some antibiotics, I'm going to send you home. You're going to be much better in 3 to 5 days. A patient might refuse that therapy and say, I don't like meds, I'm not going to take that. And that could be their choice, but I might get a psychiatry consult wondering why this patient's trying to kill themselves, because science has advanced to know that antibiotic can save their life, and that is progress. So you could fast forward to that now, to the imperative to understanding, why we're all talking about cholesterol and diabetes and weight, blood pressure, and the impact that can have on what is the number one killer and threat to every American.
Okay. And on that note, I really want to thank all of you for being here today and talking about this, such an important issue. And you guys haven't gotten the PR that you've needed for heart disease. So hopefully this can get the conversation going and more folks can, tune into this conversation and start asking questions. And it often can be as simple as asking your doctor for a panel for blood work. I want to know my lipid numbers. All right. So, yeah.
You're scared.
So everyone who's watching this online, thanks so much for joining us. All of you folks who are here in the forum, we really appreciate it. And a special thank you to the Cohn family Leslie, Stephen, Roberta, thank you all so much for this opportunity. If you want to watch this on demand, you can watch it on Harvard Chan's YouTube channel. In case you want to rewatch over and over again, you'll get the PR you need. Have a great day, everyone. Thank you.
Thank you.